Imagine you're in perfect health. You're hiking up this beautiful, rugged mountain trail.
Sounds pretty nice.
Right. The air is crisp, the views are incredible, and then completely out of nowhere, you just start to drown.
Oh, wow.
Not in a lake, not in a river. You are on dry land, miles away from any body of water, and yet your lungs are actively filling with fluid.
Yeah.
You're basically drowning from the inside out. I mean, how is that even physically possible?
It really sounds like the setup to like a physiological horror movie, honestly. It's so hard to fathom that your own body could just turn against you like that.
Yeah.
But this is a very real, very dangerous mechanical crisis that can happen inside the human chest, and often with terrifying speed.
And that is exactly our mission for today's deep dive into the sources. We're going to decode the fascinating mechanics of pulmonary edema. We really want to understand the exact physics of how fluid ends up, backing up into the air sacs of your lungs.
Yeah, and we are pulling from a really rich stack of material today to answer that. We have medical history, modern physiological models, and some massive landmark clinical trials.
Trials that totally upended how doctors understand the physics of human breathing, right?
Absolutely. They completely changed the game.
So we are going to break down some major historical misconceptions, explore famous medical failures, and show you how the body's incredibly delicate fluid balance can tip into total crisis.
It's a delicate balance for sure.
But to understand how you can drown on dry land, we really first need to look at the invisible plumbing that normally keeps your lungs perfectly dry.
Exactly. And that takes us straight to the anatomy. When we talk about pulmonary edema, we're basically looking at the abnormal accumulation of fluid in the extravascular spaces of the lung.
Okay.
But, I mean, it happens in a very specific sequence. It starts in a place called the interstitium.
Let's try to visualize that. The interstitium, that's basically the loose connective tissue wrapping around the blood vessels and the airways, right?
Yeah, precisely.
It acts almost like like a microscopic sponge, just this buffer zone between the blood and the air.
A sponge is the perfect way to think about it.
Yeah.
But, once that sponge is completely saturated and overwhelmed, the fluid has nowhere else to go.
Right, it's totally full.
Exactly. So it's forced to flood outward into the alveoli, which are the tiny balloon-like air sacs where the actual exchange of oxygen and carbon dioxide happens.
And this is where it gets incredibly dangerous for a patient, because normally oxygen easily crosses this super thin layer of something called surfactant to get into your blood.
Right, surfactant.
And from the sources, surfactant acts a bit like dish soap. It breaks the surface tension inside that tiny air balloon so it doesn't just collapse on itself.
Yeah, it keeps the balloons open. But when those air sacs flood with fluid, that delicate soapy film is just washed out or completely buried.
So the physics of gas exchange just completely break down.
They do. The oxygen suddenly has to cross this thick, heavy layer of liquid. And gas simply cannot diffuse through liquid fast enough to meet the body's demands. The whole process becomes highly inefficient, and the patient becomes acutely, severely short of breath.
I do want to clarify one anatomical distinction here because the terminology can get a little muddy. Edema is fluid inside the lung tissue itself, inside the sponge and the balloons.
Yes.
But a pleural effusion, that's fluid pooling in the empty space surrounding the outside of the lung. So they're entirely different plumbing problems, really. One is inside the sponge, the other is in the bucket holding the sponge.
They absolutely are different, even though, they can happen simultaneously in a really sick patient.
Right, of course.
But figuring out the mechanics of the internal sponge, the edema, actually takes us all the way back to 1896. And this British physiologist named Ernest Starling.
Okay, Starling.
Yeah, before his work, doctors just looked at this terrifying condition and called it dropsy of the lungs.
Dropsy. That sounds terribly vague. I mean, it sounds like they had absolutely no idea what was happening mechanically.
Oh, they didn't. They were literally just documenting a symptom.
Wow.
Starling is the one who provided the actual mechanism. He published a paper investigating this really profound question.
Which was?
Well, you have plasma flowing under pressure through thousands of miles of tiny capillaries in your body, right? So why doesn't that liquid just continuously leak out through the porous walls and pool in your tissues?
Because the plumbing is inherently porous to let nutrients out, so something has to be keeping the water in.
Exactly. Starling's answer was that there's a perpetual tug of war happening across every capillary wall.
A tug of war.
Yeah. On one side, you have hydrostatic pressure. That's the physical, mechanical pressure of the fluid pumping from the heart, pushing outward.
Okay.
On the opposing side, you have oncotic pressure. This is the osmotic pull created by large plasma proteins floating inside the blood, and they're pulling fluid back in. That delicate balance became known as the Starling principle or the Starling forces.
Okay, wait, I have to jump in here with a quick point of clarification. Because when I was reading through the source material, I got completely turned around on this.
Oh, I bet I know what it is.
I kept seeing references to the Starling forces and then to something called the Frank-Starling law.
Yep, there it is.
They sound identical, but they seem to be applied to entirely different parts of the body.
It is arguably the most common error made by students in introductory pathophysiology. I mean, it happens all the time.
I feel validated.
You should. They share the same discoverer, Ernest Starling, and they originate from the exact same era, the late 1890s and early 1900s, but they describe completely different phenomena.
So how do we separate them? Let's clear this up.
Well, the Starling forces from 1896 govern the movement of fluid across capillary walls anywhere in the body. That is the pressure tug-of-war we just talked about.
Right, capillary.
But the Frank-Starling law of the heart, developed a few years later with a scientist named Otto Frank, governs cardiac muscle itself.
Oh, okay.
It basically dictates that when the heart muscle is stretched by a larger incoming volume of blood, it snaps back and pumps that blood out with a much harder contraction.
Capillaries versus cardiac muscle. Confusing them seems like it would cause major problems when you're trying to treat a patient.
It absolutely does.
Wow.
Because, yes, a failing heart certainly causes pulmonary edema, but it's a chain reaction of pressure backing up into the lungs. It is not because the Frank-Starling muscle contraction is somehow physically injecting fluid into the air sacs.
That makes a lot of sense. So Starling maps out this capillary pressure tug-of-war in 1896. And for most of the 20th century, this is accepted as absolute textbook medical doctrine, right? Case closed.
Well, here's where the story gets really interesting. That classic 20th century Starling model is actually deeply flawed.
Wait, really? You're saying the tug-of-war isn't real?
Oh, the pressures definitely exist, but since the early 2000s, physiologists have realized that Starling's idealized simple capillary just doesn't exist in living tissue.
So what's actually there?
The true barrier stopping fluid from leaking out isn't just a mathematical equation of pressures. It is a physical, gel-like layer of proteins and sugars lining the inside of the capillary wall.
Right. The sources refer to this as the endothelial glycocalyx, which honestly, initially I pictured as a biological force field.
That's one way to picture it.
But based on the descriptions, it actually sounds more like a microscopic shag carpet or like a dense mangrove forest lining the inside of the pipes.
A dense mangrove forest is a brilliant analogy. It physically slows down the fluid, and it chemically repels those large proteins, keeping them trapped in the bloodstream.
Oh, wow.
And the other half of this revised model is that the fluid that does manage to seep through that mangrove forest isn't just sitting there in some static equilibrium.
What's it doing?
It's being continuously, actively drained away by the lungs' lymphatic system.
So it's a completely dynamic, constantly flowing system.
Exactly.
You have a gel barrier slowing the leak, and whatever slips past the barrier goes straight down the lymphatic drain. Which actually brings us to the core mechanism. If we know how this invisible plumbing is supposed to work, what happens when we break it?
Well, the fundamental rule of pulmonary edema, reduced to its absolute basics, is this. It happens when fluid filtration outruns lymphatic drainage.
Your leaky pipes are basically outputting more water than your drains can carry away.
Exactly. And based on our sources, we can trace that failure back to a few distinct systemic breakdowns.
Let's start with the most intuitive one then. Overwhelming the pipes with too much pressure. This is cardiogenic edema, meaning the root cause is a failing heart.
Right. If the left side of your heart fails to pump blood forward efficiently, that blood cannot just vanish. It has to go somewhere, so it backs up.
It's like a traffic jam.
Exactly like that. It backs up into the left atrium, then back into the pulmonary veins, and finally, it backs up into those tiny pulmonary capillaries inside the lungs.
And the pressure numbers in the source material paint such a clear picture of this escalating crisis. Like, normal pulmonary capillary pressure is roughly 8 to 12 millimeters of mercury.
Right.
But once that hydrostatic pressure climbs past 18, the fluid starts leaking into that interstitium sponge faster than the lymphatics can clear it.
And doctors can actually visualize that early spongy leak on a chest x-ray. The fluid creates these thickened lines in the tissue known as curly bee lines.
But if the pressure continues to rise, say it hits roughly 25 millimeters of mercury, the sponge completely fails.
Total failure. The alveoli flood. On an x-ray, that massive alveolar flooding creates this classic batwing pattern of dense white shadows spreading out from the center of the lungs.
That's horrifying, and this backup isn't always a slow, chronic decline over months or years, is it? The sources detail this terrifying phenomenon called flash pulmonary edema during a hypertensive emergency.
That is a perfect example of how violently the pressure can shift. A patient might have uncontrolled blood pressure, and suddenly their systolic pressure, the force of the heart squeezing, spikes over 200.
And to put that in context, a normal systolic pressure is around 120.
Exactly. At 200, the pressure in the left atrium shoots up so aggressively that the lymphatics have zero time to ramp up their drainage.
So the patient can go from sitting comfortably to actively gasping for air in, what, under an hour?
Easily under an hour.
Yeah.
Because the pressure is simply forcing the fluid right through the walls.
And because it's purely a pressure problem, emergency doctors can treat it pretty rapidly.
They can. They administer potent vasodilators like nitroglycerin to quickly expand the blood vessels.
Which drops the hydrostatic pressure.
Exactly, and reverses the process almost as fast as it started.
So if high pressure blows past the barrier, what happens if the barrier itself is just physically destroyed? That brings us to non-cardiogenic edema, where the heart is pumping perfectly fine, but the lung plumbing just gets shredded.
Yeah, this is a condition known as ARDS, acute respiratory distress syndrome. It's triggered by immense systemic insults. Think severe sepsis, major trauma, pneumonia, or, as the entire world witnessed recently, severe COVID-19.
The virus or the bacteria aren't just making you cough, they're actually triggering an immune response that wrecks the plumbing.
Spot on. Inflammatory mediators circulate in the blood and directly attack the capillary walls. They basically, punch these tiny holes in that mangrove forest we talked about.
So the membrane becomes completely incompetent.
Right. It leaks profusely, regardless of what the hydrostatic pressure is.
So even at a totally normal pressure, like 10 millimeters of mercury, the fluid just pours out because there's literally no wall left to hold it in.
Exactly. And the drainage side of the equation plays a massive role here, too. The mid-century physiologist Arthur Guyton conducted experiments demonstrating that the lung's lymphatic system is actually incredibly resilient.
Oh, the 10x safety factor thing?
Yeah. It can actually increase its drainage flow roughly tenfold above its normal baseline before any edema even appears.
10 times the normal flow. I mean, that is a staggering safety margin built into our anatomy.
It's the only reason we survive minor inflammatory events, honestly.
Yeah.
But when ARDS punches holes in the capillaries or when the heart fails profoundly, that tenfold reserve is eventually maxed out.
I want to throw a physiological curveball into the mix here.
All right, let's hear it.
So far, this stems from a failing heart or a massive systemic infection, but I was reading the sections on negative pressure pulmonary edema, and the physics absolutely blew my mind.
Oh, yeah, it's wild.
You can have a perfectly healthy heart, zero infection, and still flood your lungs through pure, violent mechanical force.
It perfectly highlights that we are ultimately just dealing with a mechanical plumbing equation here. The classic scenario happens when a patient is waking up from anesthesia.
Right. The breathing tube is removed, but their vocal cords suddenly spasm shut, a laryngospasm, so their airway is completely blocked, like a cork in a bottle.
But their brain is panicking.
Exactly. It's telling their diaphragm to inhale as hard as it possibly can. So they're generating this enormous negative pressure inside their chest, trying to pull air through a sealed tube.
They're acting like a giant biological vacuum cleaner.
A vacuum cleaner. And because they're creating such intense negative suction, it violently pulls the fluid straight out of the pulmonary capillaries, across the barrier, and into the air sacs.
Pulmonary edema caused by pure mechanical suction, developing in minutes with a totally normal heart.
It really highlights the raw physical forces at play inside the chest.
And, to build on your point about healthy hearts facing extreme physics, let's circle back to that hiker drowning on the mountain from our intro.
Oh, right. That specific crisis is HAPE, high-altitude pulmonary edema. Tell me how altitude triggers this without an infection or a failing heart.
Well, the sources detail findings by physicians like Charles Houston in the 1960s, and later Peter Hackett on Denali. When a perfectly healthy climber ascends too quickly into a low-oxygen environment, usually above 2,500 meters, the pulmonary arterioles start to constrict.
In an attempt to shunt blood to better oxygenated areas.
Yes, exactly. But they don't constrict evenly, and that's the issue. Some pipes clamp shut, while others stay wide open.
So that uneven constriction is the fatal flaw.
Yeah. The heart is still pumping the exact same volume of blood, but now it's forcing all of that blood through a tiny fraction of the vessels.
Wow. So the local pressure in those specific open vessels just skyrockets so intensely that the capillaries literally rupture under the strain.
Right. A normal heart ruined by environmental pressure, creating the exact same downstream flooding as severe heart failure.
It is terrifying, but mechanically it makes intuitive sense. And you'd think, if you understand the physics, the pressures, the broken membranes, the overwhelmed drains, you should be able to treat it easily by just reversing those physics.
You think so? But that assumption actually led to some of the most colossal miscalculations in modern medical history.
Oh, here we go.
Yeah, when doctors tried to fix this plumbing based purely on those old, incomplete 20th century textbook models, they ended up actively harming patients.
Let's talk about that medical hubris and these landmark clinical failures, starting with what the sources call the albumin myth.
So we have to remember that old Starling model.
Hmm.
Doctors believed that if edema was caused by low oncotic pressure, meaning a patient had low protein in their blood, the logical, foolproof fix was to infuse the patient with IV albumin.
Add protein back into the blood to restore that osmotic pull and just suck the fluid out of the lungs. I mean, it sounds incredibly logical.
It became routine, unquestioned practice in intensive care units for decades, especially for critically ill and septic patients who were leaking fluid everywhere.
But then came the SAFE trial in 2004, right? The saline versus albumin fluid evaluation.
And that's the one. It involved nearly 7,000 ICU patients across Australia and New Zealand.
They compared giving albumin versus just plain saline. What did the data actually show?
There was zero survival benefit. Giving albumin didn't save them. In some subgroups, it even trended toward worse outcomes.
Decades of deeply ingrained medical habit, completely undercut by a single trial. Why did it fail so spectacularly?
It all comes back to the revised model and that mangrove forest, the endothelial glycocalyx.
Oh, right.
In a critically ill patient, that gel layer is physically shredded. It is no longer a barrier. So when doctors infused heavy albumin proteins into the blood, those proteins didn't stay in the vessels to pull water back.
Where did they go?
They immediately leaked out through the shredded mangrove forest and into the lung tissue.
Oh, wow. So the protein ends up on the completely wrong side of the wall.
And because albumin exerts an osmotic pull wherever it goes, it actually reversed the gradient. It started actively pulling more water out of the bloodstream and into the flooded lungs.
That is just a staggering realization.
All right.
The century-old textbook model sounded logical, but because it was mechanistically incomplete, doctors were literally unknowingly fueling the edema.
Exactly.
And there was another huge controversy in the sources, this one regarding ARDS when the capillaries are physically damaged. It's known as the fluid paradox.
Yeah, the Apicon-TT trial from 2006 tackled this massive debate in critical care. If you have a patient in septic shock, their blood pressure is dangerously low, and their kidneys are failing from lack of flow.
The overwhelming medical instinct is to pump them full of IV fluids to support their failing system, right? You want to fill the pipes to keep the pressure up.
But the trial proved that once a patient was stabilized out of immediate life-threatening shock, a conservative fluid-restrictive strategy actually improved lung function and got them off the ventilator significantly faster.
Faster than a liberal fluid strategy. Because,
right.
I mean, if the capillary membrane is already punched full of holes from the infection, pouring massive volumes of fluid into the pipes doesn't stay in the pipes to fix the shock.
Not at all. It just gives the leak more water to flood into the lungs. You don't cure the shock, you just drown the patient faster.
It's a high-stakes confirmation of the underlying physics, proving you just cannot outhydrate a shredded membrane.
You really can't.
Now, in the real world of an emergency department, the sources point out that this isn't always a clean textbook binary between a pressure problem and a membrane problem. A lot of times, it is a very messy spectrum.
Oh, yeah. Sepsis is the perfect example of that gray area. A severe infection releases those inflammatory mediators that directly damage the capillaries, creating a non-cardiogenic leak.
Right.
But severe sepsis also chemically depresses cardiac function. It physically weakens the heart muscle. So the pump is failing, causing pressure to back up, while the pipes are simultaneously dissolving.
How does a clinician even begin to untangle that at the bedside to figure out which mechanism is driving the flooding?
Well, they rely heavily on bedside ultrasound to physically look at the heart's squeezing function and examine the lungs in real time. They also run specific blood tests like BNP.
What's BNP?
BNP is a peptide released by the heart muscle cells when they are overly stretched and overloaded. So a high BNP strongly suggests that a cardiogenic pressure-driven component is a major factor in the crisis.
Okay, I have one more massive misconception I have to ask about because it is featured on every single medical TV drama I have ever seen.
I think I know where this is going.
Whenever a character has fluid in their lungs on TV, they invariably start coughing up this highly dramatic pink frothy sputum. Doesn't everyone with pulmonary edema present exactly like that?
It looks fantastic on television, but it is a massive myth that you can rely on it for an early diagnosis.
Oh, really?
Pink, frothy sputum does happen. The pink is just from ruptured capillaries, and the froth is the fluid mixing with the surfactant soap, but it is a very late, very severe, and relatively rare clinical sign.
So if a doctor's waiting to see pink froth, they're way behind the curve.
They would miss the vast majority of real cases. Think back to Arthur Guyton and that tenfold safety factor of the lymphatic system.
Right, the drains.
Because the lymphatics can ramp up drainage so drastically, early heart failure actually hides in plain sight. Patients can have severely elevated cardiac pressures and fluid slowly seeping into the interstitium sponge with zero overt symptoms.
So by the time they are coughing up pink froth, the entire drainage system hasn't just failed, it has completely collapsed.
Exactly. Most patients present much earlier and much more subtly. They might feel generalized breathlessness when walking. A doctor might hear fine crackling sounds through a stethoscope as the small airways pop open. Or, very commonly, they present with something called orthopnea.
The sources mention orthopnea, but what is the actual mechanism there?
It's when a patient feels incredibly short of breath when they lie flat in bed. So they have to sit upright or prop themselves up on 3 or 4 pillows just to sleep comfortably.
Why does lying flat matter?
Well, when they stand or sit, gravity pools their blood volume in their legs. But the moment they lie flat, all that fluid shifts back up into the chest, massively increasing the hydrostatic pressure on a weakened heart that simply cannot handle the extra volume.
Wow. Gravity alone tips the startling forces over the edge. Sitting up literally helps drain the plumbing. That is fascinating.
It really is all just plumbing and physics.
We have covered so much ground here, from 19th century tug-of-wars to microscopic mangrove forests, high-altitude physics, and massive clinical trials that changed how we practice medicine.
We definitely covered a lot.
Why is it so crucial for you, listening right now, to actually understand this complex plumbing?
Because this specific physiology is playing out everywhere, every single day. Heart failure, which is the leading driver of cardiogenic edema, is one of the most common reasons for hospital admission in adults over 65 in the United States.
So if you have an older relative in the hospital for a heart failure exacerbation, this exact tug-of-war is happening in their chest right now.
Precisely. And it extends far beyond just heart failure. The COVID-19 pandemic was essentially a massive global public health crisis of non-cardiogenic capillary membrane injury.
Millions of people drowning in protein-rich fluid because a virus basically punched holes in their cellular plumbing.
Yeah. And as we saw with Hep D, this affects perfectly healthy young people too.
Right, with the explosion of high-altitude tourism people traveling to trendy ski resorts in Colorado or trekking to Everest Base Camp.
Exactly. Understanding how environmental pressure impacts your internal plumbing is a vital safety issue.
The overarching takeaway from all our sources is that pulmonary edema is never just a single isolated disease.
Never.
It is always a mechanical plumbing failure. No matter the trigger, a failing pump, a torn membrane, or extreme altitude, it always comes down to fluid filtration simply outrunning lymphatic drainage.
It's a delicate, continuous balance that keeps us breathing every second of every day.
Which brings us to a final thought for you to ponder long after this deep dive is over. We learned today that the lungs' lymphatic system can quietly, invisibly ramp up its drainage capacity tenfold.
Yeah, 10 times the normal rate.
It hides the early stages of massive fluid overload completely from our awareness, compensating perfectly until the very last second.
It raises a pretty profound question about the rest of our anatomy.
It really does, if your lungs are doing that right now. Well, what other silent physiological safety buffers are working overtime in your body, completely unnoticed, keeping you perfectly balanced until the exact moment they run out of capacity?
That's a slightly terrifying but amazing thought.
So the next time you are hiking up a beautiful mountain, take a deep breath of that crisp air and maybe say a quick thank you to your endothelial glycolytics and your lymphatic drains, because they are definitely doing a lot more work than you think.